In this narration, I'm going to pick up and talk about gastritis. So, gastritis is, by definition, an inflammation of the stomach. Okay, so you've got the itis at the end. Remember, that's always an inflammation. Here, we're specifically usually talking about the mucosal layer of the stomach. Gastritis can be acute or chronic. And I talked about acute gastritis because probably all of us have had acute gastritis. It's a sudden inflammation in the lining of the stomach. It can cause severe pain. It's usually temporary, lasts for just a little bit, okay? It comes and it can be caused by a stomach injury. It can be caused by bacteria, viruses, so like your GI bugs, okay? Now, if it affects the intestine as well, remember we call that gastroenteritis, so that's separate. Gastritis only affects the stomach. Gastroenteritis affects both stomach and the intestines, okay? So gastritis by itself, it can be caused by a microbe. It can also be caused by alcohol. NSAIDs will cause it. Steroids, because of the effect on the mucosal layer. Okay, because remember that they also inhibit prostaglandins, and spicy food can cause it. So remember, it's usually temporary. If you get it all the time, that becomes chronic. Now, chronic gastritis doesn't come on super fast, okay? It doesn't usually cause the intense pain that gastritis will cause, the intense vomiting. It is still an inflammation, and it can still be caused by bacteria. A lot of times, though, in this case, we're going to see it in chronic alcoholics, people who are on long-term steroids, people who have chronic stress, other immune system problems. All of that can lead to inflammation. And at that point, your stomach lining changes over time and it loses the mucosal layer. And so we do get this erosion that you can see on the slide there. And eventually we get ulcers. Another thing is that they lose their appetite. So they feel, they feel full faster. Okay, after just usually a few bites of food, and that's because the stomach is so irritated. So where you're more likely to see the ulcers with a chronic gastritis. Acute gastritis does not last long enough for you to get an ulcer. Okay, eventually gastritis will cause cellular changes as well. And I kind of hinted at this, but I don't know that I actually flat out said it. But all of these chronic stomach conditions, so your ulcers, your chronic gastritis, these are precursors to gastric cancer. Because of all of these repeated changes to the cells, it causes changes in the cells. If you remember metaplasia and dysplasia, we will start to see this in the cells. Those are precancerous changes. And if we don't treat it, then it will lead to gastric cancer. So gastritis is also one of those things where even if it's not technically peptic ulcer disease, then, we will still see that. So peptic ulcer disease, remember at this point, we've got an ulceration in the mucosal lining. It's like the tail end of the esophagus, the stomach, or the duodenum. Typically, peptic ulcers are in the duodenum. Duodenal ulcers are typically caused by H. pylori. We talked about that in class. I think I've got that on the next slide. Yeah. So you can get acute ulcers. You can get chronic ulcers. Chronic ulcers tend to be there. They'll bleed, and then they'll stop. And then they'll bleed, and then they'll stop. Acute ulcers are seen. You've got, a lot of times you'll have an active GI bleed with them. Okay. Superficial, though, that's what they are at first. You've just got some erosion here. And then once they erode through that top layer, remember, I've got a picture of it right here. Remember, here's this erosion. Now we've gone through the mucosal layer into the actual stomach tissue itself, okay? And now here we're even deeper, okay? So just remember that the deeper the ulcer, the more vascular the tissue is, and so the more blood. Zollinger-Ellison syndrome, I mentioned this. This is peptic ulcer disease along with foul-smelling diarrhea. And then I think in both sections I got sidetracked by talking about how I didn't usually talk about this, but it was on the HESI per some student. I don't think I added in Zollinger-Ellison syndrome is caused by tumors. And so you get tumors that make your stomach, the tumors are actually secrete a lot of gastrin, okay? So a lot of gastric acid, or a lot of gastrin makes your stomach produce a lot of acid. That's what causes the peptic ulcer disease, okay? Now, the tumors, though, they're usually in your pancreas or around your pancreas, and they prevent the digestive enzymes from coming out. So in a few slides, we're going to talk about pancreatic cancer. Remember that causes malabsorption issues, and maldigestion. So with Zollinger-Ellison syndrome, you can't break down the food. So what you end up with is those fatty stools, that steatorrhea, foul-smelling stools, diarrhea, from that dysfunction, okay? So you've got peptic ulcer disease, and you also have this foul-smelling diarrhea. All of it, the ultimate cause from all of it is that ulcer, that tumor. All right, so duodenal ulcers. Most commonly, we're going to see duodenal ulcers. I showed you some pictures. You've seen you've got this picture here where you can look and see that top layer is not really vascular. That's that mucosal layer, okay? Most common cause of a duodenal ulcer is going to be H. pylori. We've talked about this. How do we treat it? We treat it with antibiotics and antacids. You're going to go on antibiotics for several weeks. And we call it triple therapy because there's usually 3 things. You get an antacid and a couple antibiotics, sometimes just one antibiotic and a couple antacids. But we're going to kill off the H. pylori, okay? H. pylori produces a chronic inflammation of the duodenum, okay? You can also get duodenal ulcers from too much stomach acid. You have a hypersecretion of stomach acid. That will come from high gastrin levels, which can be caused by those tumors in Zollinger-Ellison syndrome. It can also be caused by cigarette smoking. A lot of things will trigger that production of acid. Now, gastric ulcers, on the other hand, when we have a peptic ulcer actually in the stomach itself, a lot of times you don't have excess acid secretion. You actually the mucosal layer just doesn't keep away the acid as much. So these are not as common. Gastric ulcers aren't as common. We're going to see these more in alcoholics, okay? And then we've got the stress ulcer. So remember that a stress ulcer is not really related to your psychological stress because you got exams coming up or this or that. This is one that is related to a severe illness, a trauma, something like that. You've got ischemic ulcers, which are literally caused by ischemia to the gut, okay? So these occur within hours of a huge trauma, burns, hemorrhage, sepsis, anything that reduces the blood pressure and thus pulls the blood supply away from your GI tract, okay? Because remember that your stomach is not an essential organ, okay? Your brain and your heart are, and that's what your body will pull that away from, okay? Cushing's ulcers are specifically from a head injury, a traumatic brain injury. So somebody who went through a windshield. Okay, that's a traumatic brain injury. Fell out of a window onto their head. That's a traumatic brain injury. I mentioned in class that they're also called curling. I looked this up to make sure that I was right. Curling ulcers are specifically with burns. That's what we call the ischemic ulcers that occur with burns are called curling ulcers. Cushing ulcers were named after some dude named Cushing. Has nothing to do with Cushing's disease. Another dude named Cushing, apparently. So anyway, I just wanted to correct that because I did say that wrong in class. I said that Cushing and curling were the same. All right, post-gastrectomy syndromes. We'll talk briefly about these. We'll go into detail on a couple of them. I'm going to skip dumping syndrome for a minute because I've got a couple slides on that. Alkaline reflux gastritis. So remember that if we bypass the stomach or remove the stomach or shrink the stomach, any of those things, we have less time in the stomach. We have less acid in the stomach. As a result of that, you don't get acid reflux. If they get reflux, they get alkaline reflux. Because remember that your intestines secrete alkaline things because they have to neutralize what's in the stomach. Afferent loop obstruction. This is when so in a lot of these surgeries, there's a little piece of the intestine that kind of is what we call a blind pouch. It because we'll attach the just like the little piece of the stomach that's left, because they always usually leave one little section of it, and they attach that to a spot further on down on the intestine. Usually it's like the jejunum. And what happens is you've got this little tail that sticks off, and that little tail doesn't go anywhere. That can get obstructed because things will kind of shift into that. Afferent loop obstruction is literally when that gets obstructed and it solidifies and it causes pain. Okay. Diarrhea is simply moving through too fast. Okay. We have eliminated the stomach, which holds food, holds a food bolus, and then, slowly it leaks out of it. And at this point, we're just shooting through. Okay. Weight loss is kind of the point, unless we've taken out the stomach because of cancer. Anemia, we talked about this in class. Remember that your stomach is where we absorb B12. Your stomach is where intrinsic factor is created or is secreted, and intrinsic factor is necessary for B12. If you don't have a stomach, or if you don't have a very big stomach, you're not making any intrinsic factor, or you're making very little, and that means your B12, no matter how much you eat, is not absorbed. We have to replace that, and we're going to typically replace that as an injection as opposed to PO, because it doesn't matter. I mean, you could take a whole bottle of B12. If you don't have any intrinsic factor, you're still not going to absorb it. That's a pernicious anemia, and we're going to talk about that when we talk about hematology later on this semester. And then finally, bone and mineral disorders. Again, you're not absorbing the vitamins and the minerals that you need. So specifically here, we're talking about calcium. If you're not getting enough calcium through your diet, you're not absorbing it, then your parathyroid gland is going to secrete parathyroid hormone, and it's going to leach it out of your bones, causing osteoporosis. All right, dumping syndrome. Dumping syndrome is when it rapidly empties from the stomach, or that leftover piece of stomach into the small intestine. And at that point, it just goes really, really fast. Okay. How's it happen? Well, you don't have that gastric capacity. You don't have that stomach pouch to hold it. Okay. And then the duodenum is bypassed, and the duodenum is what triggers all of this. Okay. So with dumping syndrome, usually this is going to occur right after eating, especially if you've got a meal that's high in carbs, high sugars. And your patient will get nausea, vomiting, abdominal cramps, and diarrhea. They'll feel very flushed. They'll get dizzy, lightheaded. Their heart rate will shoot up, and then it'll result in diarrhea. It's typically at that point relieved. Okay, once they've pooped it all out, boom, it's fine. Okay, and then I've got this little cartoon just to remind you. Here you go. It dumps from the stomach into the duodenum, and then it just keeps going, okay? So how do we prevent that? We tell people, limit your carbs. You need a low-carb diet for this. And then also, if you drink a bunch during your meals, it's just going to push it through even faster. So I told you about the girl I went to high school with who does this deliberately when she's at the seafood buffet. She gives herself dumping syndrome so she can get her money's worth. There you go. All right, malabsorption syndromes. Remember that when we have malabsorption, we're talking about vitamins and minerals here, okay? Typically, sometimes protein too, it depends. And a lot of times it's started by maldigestion. So anytime we have maldigestion, that's a chemical process where we break the food down. That starts in the mouth with the saliva, and then it moves on. If you don't ever digest the food, you can't absorb it. Okay, digestion comes first, absorption comes after. When you don't digest the food, it passes through unchanged. Okay, so if you have maldigestion, you will often end up with malabsorption, pretty much always. Now, you can have malabsorption by itself, it just depends. So one of the things that can cause these is a pancreatic insufficiency. And here again, we're talking about the exocrine pancreas. And we have insufficient production of our pancreatic enzymes. Big ones here, amylase and lipase, okay? And why might you have an insufficient production of them? You might have pancreatitis. You might have pancreatic cancer. We may have removed your pancreas because of cancer. You may have cystic fibrosis, in which case the pancreas has essentially died because all of the secretions are so thick that it just clogs itself up. Pancreatitis is where it's blocked into the pancreas, and we'll talk about this later, but pancreatitis is literally self-digestion of the pancreas. A lot of times it's caused by your common bile duct being blocked. Why might your common bile duct be blocked? A lot of times from gallstones. Here, the problem is that they can't digest fats. So fats are excreted unchanged, meaning you've got those fatty stools. That's steatorrhea, okay? And they'll lose a ton of weight because they're not digesting the fat. Along with that, though, they're going to not be able to absorb their fat-soluble vitamins. Lactase deficiency, this is lactose intolerance. They cannot break down lactose. Therefore, the lactose in this, it isn't broken down. It stays in the stool. It begins to ferment, and that causes gas, abdominal cramping, bloating, and a lot of diarrhea there. All right, bile salt deficiencies. These are made by the liver. If you have a bile salt deficiency, it's probably from a liver disorder. And as a result of that, we can't absorb our lipids. So bile is what digests fat, okay? And if you don't digest the fat, you get fatty stools again, diarrhea, loss of fat-soluble vitamin again, okay? So remember, those are A, D, E, and K. I do have a list on the next slide that shows you what they do. I just want to point out that vitamin D, if you don't have vitamin D, then you can't absorb calcium. And if you can't absorb calcium, then your parathyroid gland will leach it out of your bones. If you don't absorb vitamin K, lack of vitamin K causes you to bleed. This is not real. Somebody was asking about this. This isn't really hemophilia, although I guess technically it could be. It is. Hemophilia is a very broad categorization that we'll talk about. But a lot of times that's a deficiency of a clotting factor. This is a nutritional issue. If you can't absorb vitamin K. But honestly, I don't think I've ever had somebody with a vitamin K deficiency. So we don't know what vitamin E does. We think it supports the immune system. All right, inflammatory bowel diseases. So we remember that this, as I said in class, IBD is different from IBS. The inflammatory bowel diseases are typically when we talk about them, we're talking about Crohn's disease and ulcerative colitis. Now, there are other things that are inflammatory like appendicitis and diverticulitis, but if you hear somebody referring to inflammatory bowel disease, they're probably referring to Crohn's and ulcerative colitis, okay? These are autoimmune. We know that we know this, and they are relieved by some of the biologics that we give to other people with autoimmune diseases. They cause a lot of absorption issues, and they don't just occur in women though, which is something that's different with most of our autoimmune diseases. All right, ulcerative colitis. This is a specifically in the large intestine. So as I pointed out in class, they're very similar. They're treated a lot the same way. You got to be able to distinguish between the two. One of the ways you distinguish this here is that ulcerative colitis is only in the large intestine. Okay, they get diarrhea. A lot of times it's bloody stools because this literally does cause ulcers. Okay, in the colon. And so we've got to stop the diarrhea because they get they get fluid and electrolyte imbalances. The bloody stools cause anemia, typically an iron deficiency anemia, because when you're pooping out blood, you're pooping out the iron that is typically recycled by the body into new blood cells. So But again, this is, and then other nutritional deficiencies that we'll see only in the colon. Crohn's disease, on the other thing, is any part of the digestive tract, okay, mouth to butt. And it is often difficult to distinguish based on symptoms. And so basically they do a colonoscopy and they'll do an EGD. Crohn's disease causes something called skip lesions. But it's still ulcers, okay? But the skip lesions, they'll happen, and then there'll be a period of bowel that is not affected, okay? And then it'll go again. They do also have absorption problems. Specifically here, we've got B12 and folic acid. So that's the kind of anemias that we're going to get here. But again, we're treating it the same way. We are going to monitor them nutritionally. We are going to stop diarrhea so that we can stop fluid and electrolyte imbalances. Those kinds of things are standard for this. With both of them, we may have to take portions of the intestines out. With ulcerative colitis, it's just the colon, it's just the large intestine. With Crohn's disease, it could be the small intestine. Like I said, I have a friend who, his small intestine, like 15 years ago, he had 26 feet of it removed because of Crohn's disease. Okay, so this is, it can be really serious. And we'll talk about the biologics and how, because we don't want to put people on immunosuppressants for the rest of their lives. And the biologic medications really, they are amazing for these autoimmune diseases. All right, diverticulitis. Again, this is an inflammatory bowel disease. Here we have the little pouches that stick out of the intestine. And diverticulosis means you got them. Diverticulitis means that it's inflamed. Okay, how does it get inflamed? Probably something got stuck, like a seed or a nut or something like that. Problem is, it causes pain because they're inflamed, but also they can rupture. And like I said, I worked with a lady who had a diverticulum rupture, and she had an emergent colostomy placed because they had to take out that piece of intestine. They gave her an emergent colostomy, let it heal, and about 4 or 5 months later, she had it reversed. So but they're the little pouches, okay? And if it sticks in, a little finger sticks into the intestine, you call it a polyp. If it sticks out, it's a diverticulum. All right, appendicitis, again, another inflammatory disease because it ends in itis. And in this case, we've got, the appendix. Why? We're not really sure what causes appendicitis. There's a lot of things that can cause appendicitis. We used to just take the appendix out. If you had any kind of abdominal surgery, we'd just be like, take the appendix out too. We don't do that anymore. But it's funny because when you get old people in the hospital, they've all had appendectomies, and you're like, I don't understand. If you had a C-section, they take your appendix out. If you had a hysterectomy, they take your appendix out. They would just take the appendix out for anything. So it happens way less now. Okay. If the appendix gets inflamed, you are going to get both right lower quadrant pain and some epigastric pain. Remember that it refers up. And then the big thing is that rebound tenderness. Rebound tenderness is caused by an inflammation of the peritoneum. Rebound tenderness is caused by peritonitis. That's the inflammation of the peritoneum. Anything that causes peritonitis will cause rebound tenderness, okay? So look back to diverticulitis. If your diverticulum bursts, you've got peritonitis, because you've got an infection in your peritoneum because your intestines just exploded into your peritoneal cavity, okay? You're going to have rebound tenderness here, okay? Now, you're not going to get peritonitis unless the appendix ruptures. So the trick is get it out before it ruptures, okay? All right, I'm going to stop there, and we're going to pick up with IBS as opposed to IBD in the next narration.